Globally, breast cancer is the most frequently diagnosed cancer in women. This medical reality has created a massive secondary industry of fear and digital misinformation. Women navigate their daily lives attempting to dodge an endless stream of rumored carcinogens, often second-guessing every household item and routine habit. The rumors are persistent and specific. We are told hair dyes, caffeine, or even abortions might be the hidden cause. To find the signal in this noise, epidemiologists rely on the up-to-date clinical guidelines, the definitive data source used by physicians to assess actual risk. This method ignores sensational headlines, instead analyzing the medical histories of millions of women to identify which factors truly correlate with the disease. When we apply this rigorous filter, the guessing game stops. We begin to see the specific, measurable patterns that define a woman's risk profile. The process begins by immediately eliminating the factors that clinical data proves have zero influence. Large-scale studies show no association between caffeine intake and breast cancer. The morning cup of coffee is statistically irrelevant to the disease. Comprehensive pooled analyses also rule out any link to abortion. The data from population-based cohorts confirms that both induced and spontaneous abortions do not modify risk. The list of non-factors extends further. Tubal ligations, cosmetic implants, and hair dyes all lack any proven association with breast cancer development. Clearing these common anxieties from the board allows us to focus entirely on the physiological realities that we can actually measure and influence. A woman's risk profile is built on a foundation of unchangeable biological and demographic baselines. The most universal factor is time. The statistical probability of developing breast cancer increases steadily as a woman gets older. Genetics provide another fixed layer. Inheriting pathogenic variants like BRCA1 or BRCA2, combined with a strong family history, significantly elevates a woman's starting risk level. In the United States, demographic data shows that white women face the highest overall incidence of diagnosis. While diagnosis is more frequent in white women, Black women face a 44% higher breast cancer-specific mortality rate, often presenting with more aggressive and advanced disease. These baselines, genetics, demographics, and age, set the starting point, but they don't determine the entire outcome. The primary biological engine driving this risk is lifetime estrogen exposure. This exposure window is defined by a woman's biological clock. Early menarche and late menopause both extend the years the body is producing endogenous estrogen. Mammographically dense breast tissue also correlates with a higher risk profile within this biological environment. This estrogen engine interacts directly with body mass index, but the relationship is counterintuitive. In premenopausal women, a higher BMI actually correlates with a lower risk of breast cancer. After menopause, the relationship reverses. Once the ovaries stop, adipose tissue converts chemical precursors into estrogen. This means a higher BMI consistently increases risk in later life, explaining why the body's response to weight shifts so significantly at different biological stages. While genetics and biological clocks are set, women modify their risk through specific, actionable behaviors. The data highlights several lifestyle factors that can actively move a woman's statistical odds. Alcohol consumption is a primary modifier. The clinical link is well established, with higher intake correlating to higher risk. Smoking follows a similar pattern. Multiple prospective studies show that any history of smoking is associated with a modestly increased risk. Managing postmenopausal weight is equally critical, as it serves to reduce the available estrogen precursors in the body. Addressing these exposures directly reduces the hormonal and chemical signals that trigger tumor development. Protective behaviors provide further balance. Breastfeeding, for example, offers a powerful cumulative effect against the disease. The benefit is quantifiable. For every 12 months of breastfeeding, data shows a 4.3% reduction in relative risk. Physical activity functions as a chemical regulator. Higher levels of exercise are associated with lower breast cancer risk in both pre- and postmenopausal women. Exercise actively reduces serum estrogens and insulin levels, providing a layer of protection that works regardless of weight loss. Approximately half of all breast cancers can be explained by these identified risk factors: demographics, genetics, and environment. While we cannot rewrite our DNA, the choices we make regarding nutrition and movement account for a massive portion of the risk landscape. The science doesn't demand fear, it provides a roadmap for informed choices.